My name is Eric Ansart. I am the president of Lymphopress for their US distribution arm. I'm excited to have each of you here today, and I appreciate you taking the time out of your busy evenings. And I especially am grateful for Dr. Ken Anaeme for joining us this evening. I'll take a moment to introduce him, but just before I do that, I want to speak to the topic for a moment as people are logging in about the prevalence of primary and secondary lymphedema and just what we've seen over the course of the last 4 or 5 years as the diagnosis and the recognition of the condition has become much more available and more prevalent. So I will reference a study that was done in 2019 by Dr. Stephen Dean, Elizabeth Vellante, and Karen Hawk out of a facility in Ohio. And they were actually, the study is called The Clinical Characteristics of Lower Extremity Lymphedema in 440 patients. And what is really shocking out of this actually came from a cancer facility. So you would think that there'd be a higher prevalence of cancer-related lymphedema. But the purpose of this study was to identify the different characteristics and the etiologies of the lymphatic condition. And what they found in that was that 12% of the patients had lymphedema from lipedema, which is a fatty connective tissue disorder that many of you are probably familiar with. 13% of it, so only a slightly more, were primary lymphedema cases. These are patients who have hereditary lymphedema. And then 34% of the cases were cancer related, but really the shocking number was that 42% of the patients who presented with lymphedema were there because of chronic venous insufficiency. And Medicare defines lymphedema as swelling of the subcutaneous tissue due to an excessive amount of lymph fluid, whether that is an overproduction or some type of restriction to the lymphatic channels. The importance of that is just we've recognized in the last few years that there's been an uptick in diagnosis, recognition, and treatment of this condition. And a lot of this does point to the vascular condition and the vascular kind of combined condition of venous insufficiency, which is why we're so excited to have our speaker with us today, because certainly Dr. Anaeme in his role as a wound care physician runs into the condition of secondary lymphedema quite often. So with that, I'm going to welcome Dr. Anaeme. Dr. Anaeme is a board certified physician, triple board certified in internal medicine, pediatrics, and hyperbaric medicine. He focuses his practice primarily on wound care and limb salvage. And I love the philosophy that he shares. He says, every patient deserves to be treated with dignity, respect, and consideration while actively encouraging patients to participate in their own medical decision-making process at all times. I treat patients the way I would want to be treated. And I think that speaks volumes for the speaker we have this evening. And with that, Dr. Anaeme, I will pass the presentation to you and welcome you this evening.
Thank you, Eric. So thank you everyone for attending this presentation. My role tonight, I think, is just to speak to you as providers of wound care and also primary care about what I see in my practice in terms of wound management, the incidence of lymphedema, as well as the conditions under which we find patients with lymphedema. It's been interesting in my 16 years of wound care medicine to see the connection between lymphedema as well as chronic venous insufficiency and, surprisingly, arterial insufficiency, one of the areas where people are not as much attuned to the benefits of compression therapy, because it's often thought of as a contraindication, but we will speak a little bit about that tonight. Before I proceed, however, I just wanted to clarify what we'll be talking about. We will speak about what is a wound. What do you see when you talk about a chronic wound? How does that manifest? Let's get some definitions initially, and then we will speak about the common types of wounds that we find. The arterial insufficiency ulceration, as well as the venous insufficiency ulceration and its association with lymphedema. And then we'll talk about lymphedema specifically, and then the treatment of lymphedema, specifically the role of intermittent pneumatic compression, more commonly known as a lymphopress in this setting. So if we're to speak about a wound, most of the time when you are speaking of a wound, you hear a wound and you think, well, it's an injury, and that is true. But if we're to define it technically, a wound would be a disruption in the integrity of the skin and the skin structures. We as clinicians speak of wounds in two forms. We talk about an acute wound, which is one which will heal based upon a sequential and predetermined order without complications. Note that the time of the wound is not the criteria that you use. It has to heal in a sequential and predetermined order. And a chronic wound is one that deviates from this anticipated sequence of healing. So, of course, what is the sequence of healing? We'll get to that, but let's also define some structures. So the skin structures we're interested in, the epidermis consists of the keratinocytes, the melanocytes, which give you a pigment, the Langerhans cells, which process immune responses. The dermis contains the fibroblasts as well as the hair follicles. And underneath this, you have the subcutaneous tissue, which harbors all your fat, the capillaries, the blood vessels, the nerve fibers. And then you have the fascia separating the skin from the subfascial tissues of muscle, tendon, bone, and larger vessels. These are mostly cellular components. And then you have the extracellular component of the skin and soft tissue, which is mostly the collagen as well as hyaluronic acid. Collagen is mostly type 1 and type 3 collagen in the skin. So what is a normal wound healing sequence? You have trauma to the skin, and then you have bleeding. And so the initial cascade starts with the clotting cascade of hemostasis. And this leads to degranulation of platelets with release of platelet-derived growth factor, which then leads to attraction of white blood cells to the site. And there's cell migration. There's diapedesis, which is adherence of the white cells to the blood vessel wall, and then they migrate into the tissues. And then they set up an inflammatory process. They clean up the tissue, they clean up all the debris, they clean up any bacteria that may have been introduced. This process takes about 0 to 3 days after hemostasis has occurred. The process of inflammation sets up another process which is called proliferation, where the fibroblasts come to the site and lay down collagen on the wound bed. And the collagen basically is the matrix over which your cells, the keratinocytes and the Langerhans cells, will then resurface the wound. And that process of proliferation will take about 7 to 14 days. And then after that, there will be a process of contraction of the wound, the scar that forms. And eventually you will find in about 30 days to about 60 days, you have a wound that is about 80% of the normal tensile strength of the uninjured skin. That's how a normal wound heals. Any wound that deviates from that pattern becomes a chronic wound. Most wounds deviate from the healing pattern in the stage of inflammation, about 80% of the time. About 20% they deviate at the stage of proliferation. This will make it a little bit easier to see. So we have the picture on the left, which shows the house on fire. That is the injury that has occurred. And you have the white cells showing up as the firefighters to put out the flames, the stage of inflammation. And then you have the fibroblasts, which produce the collagen, which is the scaffold. And then you finally have the keratinocytes that will resurface the wound and heal and begin the process of healing the wound and closure. So then why do wounds become chronic? There are multiple issues, but the most common reason you would find in an outpatient setting is that an acute wound becomes chronic, usually because of three basic conditions. There's infection, there's vascular insufficiency, there's malnutrition, and then there's underlying medical conditions. In the clinical classification of wounds, I like to classify wounds into 5 types of wounds. Bearing in mind, if we go back to this, why do wounds become chronic? This is why wounds become chronic in a general sense. However, clinically, it makes a lot more sense to classify wounds based upon 5 types of wounds. The venous insufficiency ulceration, which is the most common wound that you find in the outpatient setting. The arterial insufficiency ulceration, the diabetic foot ulcer, the pressure ulcer, and then the others, what would be maybe post-surgical, malignancy, vasculitis, Today, we're going to concentrate on speaking about the first two, the venous stasis ulceration and the arterial insufficiency ulceration. The other ulcerations are going to be discussions for another day, much too broad to be included in this conversation today. So your venous insufficiency ulceration is the most common type of ulceration you will find in an outpatient wound care clinic. Generally, these ulcerations are chronic, they are recurrent, and they tend to be refractory to treatment because there is often very poor compliance with management. They are located usually between the malleoli and the knee, in the so-called gaiter area of the legs. They tend to be very large ulcerations, very weepy. There's associated with a lot of exudate, and it is also associated with chronic lymphedema, a secondary lymphedema in most cases. The cause of venous insufficiency ulceration is a valvular incompetence with reflux of the superficial or the deep or the perforator veins. This is your classic venous insufficiency ulceration, a very large ulceration, which you see at the picture at the top left, between the ankle and the knee and the knees. Superficial ulceration typically doesn't extend into the fascia unless it's been prolonged. There's often edema, there's hemosiderin staining of the skin. There's evidence of previous ulceration. Your venous insufficiency ulceration, you have to assess. There are multiple assessments that must be done in order to assure adequate treatment. You need to obtain an arterial screening prior to initiating compression treatment, prior to initiating static compression treatment. We'll have a little bit more to say about this later. The treatment for venous insufficiency is lifelong compression. Sometimes you are able to intervene by doing superficial vein or perforator vein ablation treatment, which will provide relief, usually about 1 to 2 years, but the body will recanalize typically, and then you may have to repeat the procedure again. Secondary lymphedema is very common. Therefore, intermittent pneumatic compression is often applied for long-term management of the venous insufficiency ulceration. Your arterial insufficiency ulceration is caused by arterial occlusion, usually chronic, of the peripheral arterial circulation. There could be acute arterial occlusion that occurs on top of the chronic arterial insufficiency, and this is usually a medical emergency which has to be treated urgently and is usually not dealt with in the outpatient clinic. Critical limb ischemia is a term that is used to denote severe peripheral arterial disease. It is not necessarily acute, it just denotes an arterial insufficiency of a severe degree, which usually is symptomatic and requires intervention. Often arterial insufficiency is associated with diabetes and hypertension. And arterial insufficiency can also coexist with venous insufficiency, a so-called mixed arterial and venous disease. Cigarette smoking, obviously, the major risk factor for peripheral arterial disease. Usually these ulcerations are small and deep, the opposite of the venous insufficiency ulceration. They are typically located on the distal foot, including the toes, the malleoli, sometimes on the heels. They are dry, typically, unlike the venous insufficiency, which is wet. They may or may not be painful. Claudication may be classic, as in the calf claudication, or atypical. Sometimes patients complain of stumbling as a sign of the claudication. So that's a good point to remember if you find someone who's a smoker who complains of feeling weak when he's ambulating and often falling. You may actually be looking at a case of atypical claudication. There's nocturnal rest pain, which is relieved by hanging the legs down. This is a symptom that, if present, is highly suggestive of critical limb ischemia. Note that in chronic arterial insufficiency, gangrene is actually a late occurrence. It is usually a dry gangrene which occurs late. This is very distinct from the gangrene that occurs with diabetic foot ulcerations, which tends to be early and tends to be wet and tends to lead to amputations. So in pure peripheral arterial insufficiency, gangrene is a late occurrence and amputations actually tend to be a late occurrence. However, note that arterial insufficiency may actually coexist with diabetes mellitus, and it should be worked up immediately when diagnosed. Also note that coronary artery disease may coexist, and in fact often does coexist with peripheral arterial insufficiency. Angiography will be diagnostic and therapeutic if you're able to perform percutaneous intervention. You obviously encourage your patients to exercise daily to pain tolerance, and smoking cessation is critical. This is your classic arterial insufficiency ulceration, typically located distally, as in this patient located on the tip of the great toe, a dry ulceration with some necrosis. There's some association with skin discoloration in this patient, which suggests some underlying venous insufficiency as well. So lymphedema, which we're going to talk about in much more detail today, is a chronic swelling caused by excessive lymphatic fluid buildup. And it could be either from faulty or damaged lymphatic vessels, so poor clearance or an excessive production, secondary to venous insufficiency. Lymphedema could be primary or could be secondary. Estimates put lymphedema incidence at about 3 to 5 million in the US patients are suffering from, but most people think it's a lot more because there are lots of cases that are undiagnosed. There is no known cure for lymphedema, but it can be quite effectively managed and controlled if it is recognized early and also treated early. And the good news for us is that many insurers now cover for lymphedema garments and wraps. Coverage by Medicare is available for lymphedema pumps, as well as for lymphedema garments, as well as for lymphedema clinic visits. The most common type of lymphedema, as I mentioned, is a secondary lymphedema. And as Eric mentioned earlier in his introduction, it's due to chronic venous insufficiency. It's important that we distinguish lymphedema, both clinically and chemically, from peripheral edema due to, say, for example, congestive heart failure or liver cirrhosis. As I'm sure you know in your practices, most people with congestive heart failure actually do not have lower extremity ulcerations, even though they have significant edema. This is because the fluid in peripheral edema due to, say, cirrhosis or congestive heart failure is chemically distinct from lymphedema fluid. Lymphedema fluid actually is a very high protein content fluid that is found in the interstitial tissues. It is not readily excreted via the circulatory system. Lymphedema fluid is actually moved through the lymphatic vessels into the thoracic duct and then subsequently into the circulation. Therefore, diuretics are not effective for removal of lymphedema fluid, unlike in conditions like congestive heart failure. So excretion of lymphatic fluid requires a physical movement of the fluid proximally into the thoracic duct, which can be effected by leg elevation or by the provision of compression, mechanical compression. There are 4 stages of lymphedema that are recognized, starting from a stage 0, which is really a very early stage. There will be minimal discernible edema, but you may have venous reflux changes that will be present. The patients sometimes complain of a feeling of heaviness in their legs. And you move on to a stage 1 where you have early edema, which usually subsides with leg elevation. The edema is still readily reversible with compression. And this is the stage where you really want to get most of your lymphedema patients, because this is the stage where you can make the maximal amount of improvement with your treatment. Stage 2 lymphedema, you find moderate edema, which is now non-pitting, meaning that it is very difficult for you to compress the skin with pressure. It is usually irreversible with leg elevation and with routine compression. There will be fibrosis of the skin with some color changes. We have what we call cobblestoning of the skin. If you remember the cobblestone patterns you can see on the streets, the skin looks, and then you find even the stage 3 lymphedema, the progression of interstitial fluid gets much more severe, and then there's elephantiasis, papillomatosis, hyperkeratosis of the skin, deep skin creases. Just an interesting point, secondary lymphedema due to venous insufficiency is the most common form of lymphedema that we find here in the United States. However, the most common form of lymphedema worldwide is actually due to a secondary lymphedema from filariasis, which is a filarial worm infestation found in sub-Saharan Africa as well as in South America. That is the #1 cause of lymphedema worldwide, but that's just an aside. So this is somebody with chronic venous insufficiency with stage 1 lymphedema, where you now have edema of the legs. As you can notice from the picture, there's some erythema of the legs, some stasis inflammation. You have edema, you have superficial ulcerations on the leg. This edema would be readily amenable to treatment with compression. And here you have a patient who has obviously progressed much more, who now has venous insufficiency with a large ulceration on the left medial malleolus. with stage 2 lymphedema, where the edema is non-pitting, brawny, extending up to the knees with chronic hemosiderosis. Noted, hemosiderosis is the hemosiderin staining that you see on the legs, the brown staining, which is caused by deposition of iron pigmentation from red blood cells that have migrated into the subcutaneous tissues because of the leakage of the capillary vessels. And here you have even further worsening of lymphedema with somebody with a very large chronic venous insufficiency, ulceration on the anterior and posterior legs, with stage 3 lymphedema at this time. This is a leathery skin with elephantiasis and papillomatosis and a large chronic ulceration of the legs. And here you have another patient who has significant elephantiasis with what we call hyperkeratosis, so excessive thickening of the skin of the legs with deep skin creases, and lymphoria, which is weeping drainage from intact skin, but there's such severe edema that the drainage comes through the skin. There's often a lot of odor. There's often a lot of recurrent superficial cellulitis with this condition. And this is another picture of someone with severe lymphoria, hyperkeratosis with weeping lymphoria, as you can see. Again, very diffuse ulceration on the thigh, but a very large, brawny, non-pitting edema of the legs. So when you identify this, how do you then assess and how do you treat? So we really have to have a very high threshold, a very low threshold for identification of patients with lymphedema. So anyone in your practice who comes in with chronic venous insufficiency, who has varicose veins, who complains of heaviness in the legs, you really need to be on the lookout for that. The other causes of secondary lymphedema, somebody who's had prior radiation therapy, especially somebody who's had maybe breast cancer, mastectomy, radical lymph node dissection with adjuvant radiation therapy, someone who complains of leg swelling since adolescence, usually the so-called lymphedema precox, somebody who has bilateral leg swelling as a child, that is from lipedema, which Eric mentioned earlier. Morbidly obese people with large abdominal pannoses, which sit on their thighs when they sit down and cause mechanical obstruction of the venous return from the legs. So you need to document all these, and you need to be very alert to the possibility that there is lymphedema, and you need to begin assessment and treatment quite early. You document the leg circumference, you document any previous treatments, document your findings very early in your first or second visit. Document things that would indicate a much more severe lymphedema. If you have skin showing papillomatosis, hyperkeratosis, elephantiasis, cobblestone appearance of the legs, or lymphoria, which is again drainage of fluid, lymphatic fluid from intact skin or from ulcerations. And after you document this, then what do you do? How do you treat lymphedema? The gold standard of lymphedema treatment is a technique called complete decongestive therapy. Complete decongestive therapy has several components of it. There's manual lymphatic massage and wraps, and there's short stretch compression wraps, which you can use Uno's boots and multi-layer wraps, exercise, as well as skincare. As you see from the previous pictures, there are lots of components of lymphedema, and some of the most distressing could be just the general hygiene issues associated with severe lymphoria and chronic weeping skin. So complete decongestive therapy is usually initiated in the setting of a lymphedema clinic. However, lymphedema clinics tend to be few and far between. So primary care physicians, as well as those in wound care, should be able to perform some of these elements of complete decongestive therapy, even if not the full formal therapy. You can address the skin issues, you can address exercise, weight loss, initiation of compression wraps as needed, manual lymphedema treatment, and then we come to the adjuvant treatments, the maintenance treatment of lymphedema, which is what we'll be talking about next, which is the use of the intermittent pneumatic compression device to provide lifelong, daily, active compression therapy. So what is the Lymphopress device? What is intermittent pneumatic compression? This is a device which provides an external pulsatile compression moving from a distal to a proximal order so that you can mechanically move your lymphatic fluid along the lymphatic channels proximally to facilitate absorption into the thoracic duct and eventual excretion via the circulatory system. So it recruits lymphatic channels to facilitate the removal of the lymphatic fluid. And it does this mechanically, but not only does it do a gross mechanical movement of the fluid through the lymphatic channels, but there are also multiple sub-physical or chemical actions that actually occur during the process of compression of the legs at the level of the blood vessels, as well as at the level of the interstitium. So there's improved tissue oxygenation which occurs. And how does this occur? Well, if you imagine that there's lymphatic fluid, there's edema of the legs, the tension, there's a tissue expansion, and there's a deficit of oxygen at the level of the skin because the ability of oxygen to diffuse to the skin through the capillaries has been decreased by the presence of the fluid. Therefore, simple removal of the fluid by removal of the edema will actually increase. Studies have shown that your transcutaneous oximetry monitoring of the skin level actually shows improvement in skin oxygenation tension when you decrease the edema by providing compression. Also, there's decreased pain as well from decrease in the tissue tension. Also, interestingly, there is a decrease in the ability of, there's an improvement and a decrease in clotting ability, which actually facilitates less of a risk for deep vein thrombosis when you actually put intermittent pneumatic compression. And there are many theoretical mechanisms where this or why this occurs. And some people think there is an enhancement of fibrinolytic activity at the tissue level, which actually makes it less likely to obtain it or to develop a deep vein clot when you're treated with intermittent pneumatic compression. There are decreased rates of soft tissue infection with regular use of the pump because there's decreased edema and there's decreased lymphoria. This is a comparison study that showed an Unus boot only with an Unus boot using a vasopneumatic compression device. And it actually revealed a very interesting finding, which was there was a 30%, it's an intuitive finding, but it was nice to confirm there was a 30% decrease in the number of days to heal in patients who were treated with both pneumatic compression with a Lymphopress device and static compression and Unus boots versus those who were treated with Unus boots alone. And this, of course, makes intuitive sense because an Unus boot is a static compression alone, requires the patient to be mobile in order to be able to activate the calf pump in order to work, whereas the lymphedema pump is an active compression, which does not require the patient to actually be mobile in order to recruit lymphatic vessels and in order to move the fluid along with the pump. So what is the protocol that we use for the Lymphopress? So the lymphedema machine is typically, it comes as a standard protocol which provides about 40 to 60 millimeters of mercury pressure, and you treat about 45 to 60 minutes twice a day. And you can use it much more frequently depending upon the severity of the edema and of course the progress with resolution. You can apply this directly over any compression wrap, including the Unus boot. You can also apply it directly over your compression stockings. It comes in multiple sleeve sizes and configurations, so it can be used anywhere where there's chronic edema, including on the upper extremities, on the trunk, even the head and neck. There's lifelong treatment. This is lifelong treatment, to prevent recurrence of the ulceration. And here we have some examples of the classic Lymphopress pump. This is a full body device with sleeves on the legs and providing also some compression treatment on the trunk. And here you have other examples. Someone with the short leg pump and the long leg pump, and on the left bottom you find a thoracic sleeve, an arm and thoracic sleeve. So some final thoughts I will leave with you is consider early the need for a lymphedema pump. Start when in stage 1. You don't want to wait until the late stages, which may be poorly reversible or in fact irreversible. Document very well the need for the device, the presence or absence of an ulceration, and the etiology of the lymphedema and the previous treatment that you have tried. And you also need to connect with a DME provider who specializes in the delivery of these devices. Frequent patient encouragement is needed. The treatment of lymphedema is a lifelong process, and you have to continuously encourage your patient to be adherent to this treatment. The treatment does take time. It is 40 to 60 minutes twice a day. So it is a significant burden on their time, but if you can convince them to stick with the treatment, they will be very happy with the results. And also consider other patient clinical issues which may be present but unspoken, and offer management if you're able to. Address the issue of weight, address the issue of diabetes, address the issue of smoking cessation. And with that, I'll be happy to take any questions that you have. Thank you very much.
Thank you very much, Dr. Anaeme. There are a couple of questions here that we can start out with. So there's one question initially that I did provide a response to through the typed chat, but the question is about clearing the more proximal area before using the device on the more distal part of the extremity. Is there any benefit to clearing the, say, the trunk area before using the pump on the legs or arm?
No, I would say no, not really. Well, because first of all, your device, as we showed in some of the slides there, you do have different garments which can provide sequential compression from distal to proximal. So you can actually have a truncal component to your garment that would treat at the same time. So you don't have to do it in a stepwise fashion. You can treat immediately. So I think you have to work with your DME provider to get the appropriate, and this is why it's critical to work with someone who really is versatile with the pumps, who knows how to size your patients and to get the appropriate device for your patient. So I think the sequential treatment from distal to proximal, including the trunk, can be done at the same time.
That's excellent. Since I represent Lymphopress, I can speak for our product. Our advanced line does have a decongestive mode, as Dr. Anaeme mentioned, where the more truncal or the more proximal area will be cleared prior to distal therapy. That being said, there are some insurances and there are times where that device may not be available to a patient because of reimbursement. And in those situations, we typically recommend that the patient does some type of self-massage or self-therapy in the more proximal areas if necessary. Obviously, in an ideal world, every patient gets the best treatment possible, but we try to work with patients as we can. Another question here says, what can be done to help lymphedema at the top of the arm above the Lymphopress sleeve? My clinic does not have the version that includes the torso. Let me address the Lymphopress side of this, since this seems to be more of a product question. First thing I would say is if you have a clinic where you're using this device and you don't have the more proximal portion for treatment, contact Lymphopress and we'll see if we can provide that for you, because I think that's an important therapy to be able to provide to your patients. And then I think to answer the question about the upper arm therapy, if you're a patient and you're at home, then kind of let's reference the first point, that maybe more hands-on massage or using a static compression garment. I know something as simple as a Spanx type product, but there's a lot more medically advanced garments that a patient can wear to treat the trunk if necessary. Question here says, I have a patient with elephantiasis due to lymphedema from combined cause of CHF and morbid obesity. He often complains of itching, pain of his legs and skin. What kind of medications are used to treat these from topical to oral? And is there any hope for this patient to reverse his lymphedema stage?
So it sounds like you have someone who is in a late stage 3 lymphedema. And well, first of all, it's going to be a multiple modal treatment. You have to get the congestive heart failure under some sort of reasonable control. I think that would be the first essential treatment. But specifically speaking about the skin, so there are multiple topical emollients. I've actually experienced with patients with elephantiasis on the skin and with weeping lymphorrhea. I have kind of come to one of my go-to treatments, which I'm not sure if you've tried, is to use something that is not just drying, but also I use Zeroform a lot for some of these cases, because Zeroform does tend to dry a little bit, but will also give you enough moisture to be able to actually gently exfoliate the skin. So Zeroform underneath an Uno's boot might be a way to start off with and to provide some comfort for the patient. And sometimes the pruritus is also controlled by that. We do use topical we do use topical steroids very sparingly to control pruritus, especially if it's very worrisome on the initial phases. But you just have to, I believe, work with your patient and utilize some form of compression that will be adequate to move it. And there is, if you put him in a lymphedema pump and he's very well compliant with it, you should be able to get the edema down to the point where you begin to actually see some significant improvement in the hyperkeratosis of the skin based upon the kind of wrap that you're applying underneath.
That's excellent. Thank you. There's another question here from Kelly. She says, regarding radiated skin, is there a concern that mobilization of radiated skin, whether manually or via pump, that there will be an increase in proliferation of the fibroblast formation?
No, so interesting question, but I would say no. So if we think about radiated skin, so what does radiated skin have? So if we think about soft tissue radionecrosis, we're talking about what are called the 3 H's. So there's hypoxia, hypocellularity, and hypovascularity. So radiation causes hypovascularity as its primary means of effect. And the hypovascularity, the destruction of the vessels, leads to hypoxia because there's no blood supply. And then the hypoxia leads to hypocellularity because the cells then die. That is how radiation works. So if you have chronically irradiated skin, so the primary problem is there's a lack of oxygen supply to the skin because there's a paucity of vascularity. So if you can actually recruit vessels, however you can recruit them. So if you've had a radiated skin and you apply lymphedema treatment, and you're actually able to, as we mentioned earlier, increase your perfusion gradient to actually improve circulation to the skin. Actually, I think you would actually be able to improve some of the delivery of oxygen to that skin. And so I think actually your incidence of ulceration should be less in that skin that has been previously radiated.
That's a great point. And I did want to bring out, you mentioned in one of your slides, you talked about it, the TCOM results, actually looking at skin perfusion, oxygen skin perfusion after the use of the device. There's been a number of studies out there that have actually shown that oxygen perfusion at the skin level after the use of pneumatic compression is beneficial. I believe you said that that happens because of the edema reduction. Is that correct? And maybe could you speak to that for just a moment?
Yeah, so there's several mechanisms. So one of the mechanisms is the reduction of the edema. So if you think about the skin surface, the migration of cells. So if you just have an increase in the capillary diffusion of oxygen from the capillaries to the skin, if there's any increase in the amount of tissue that the oxygen has to diffuse, then this is actually exponentially decreases the amount of oxygen that gets to the tissue. So TCOM studies, transcutaneous oximetry studies have been done that show that when the edema is decreased following intermittent pneumatic compression therapy, there's actually an exponential increase in the transcutaneous oxygen measurements at the skin level. So, and most people think that you are doing this by being able to reduce the interstitial fluid and therefore reduce the diffusion rate, the difficulty with diffusion. So improve the gradient of diffusion of the oxygen from the capillaries to the skin. The second mechanism that is being done on a more macro level is that, again, if you remove if you empty the venous return, even if there is some decrease in the arterial circulation, but you empty the venous return, then you have increased what is called the arterial venous gradient, and then you actually have an increase in the perfusion. So you actually have an increased driving force into the tissue. So a little bit increased over and above what you would have if you had the edema that was present. So you may actually be able to say increase your arterial venous gradient to maybe 35 mmHg, for example, and whereas before it was 20. So that increased driving pressure actually improves the circulation of the skin, at least for some time following your treatment. So this is the mechanism by which it does actually help in cases of acute ischemia, not acute ischemia, in cases of chronic limb ischemia.
One of the questions that we've had come up, and it's not posed today, but it's come up many times in the past, is when we remove the congestion from a limb by reducing some of the edema, have you ever seen a change in a patient's ABI where they actually improve their ABI levels with that reduction of edema? So
yes, the answer will be yes. You can actually have an improvement. So we actually do ABIs that we do now. We actually don't do the blood pressure, the mechanical pressure right at the ankle, we actually have a device which measures it right off the skin perfusion at the toes. So you can actually have an improvement in that. It's called the QuantaFlow device, which actually gives you, and it's been correlated very well with the ankle blood pressure ABIs. I mean, those are a lot less sensitive because you're actually taking systolic pressure. So the QuantaFlow device is actually measuring circulation at the capillary level at the toes. So you actually do find improvement with that. If you edema, yes.
Very, very interesting. I see Laura Hayden's here. Hello, Laura. Nice to see you. She's asking a question about compression garments being covered by Medicare. I know, we've had for years now, there's been the Lymphedema Treatment Act where we've been trying to fight for, garments to be covered by Medicare patients. I think you mentioned at one point, I'm sure you're probably referencing some of the private insurance and private insurances, but she's asking about compression garments being covered for these patients.
Yes, so yes, that can be tricky. We do get compression garments covered. However, I think often they have to have a wound associated with it, so before it will be covered. And this is one of the reasons why it's also good to document your findings pretty early and request for these garments very early. And sometimes I have run into lately, it's just been in the last year that I have run into the issue where actually patient on Medicare actually had garments covered for the limb that had an ulceration, but not for the limb that didn't have the ulceration, even though they both had lymphedema and they both had venous insufficiency. I mean, both limbs had venous insufficiency. So the answer is yes, it is covered, but I believe you have to have an ulceration present for you to get Medicare to cover that compression garment.
Yeah, that is correct. There has to be an open wound. The code is A6545 for the compression garment itself, and it's considered a surgical dressing, and it's only covered when the patient does have a wound. So for a strictly lymphedema patient, I know that's still a battle that we face to try to get these covered for those patients. There's a question here from an anonymous attendee. It says, should extra precautions be taken when using a pump in an area that has a chronic leak of lymph fluid?
Well, I'm not sure I understand. If by chronic leak we're talking about the lymphoria, which is just a weeping, then I would say, well, the only caution that would be taken would probably just be hygiene issues. But if we're talking about perhaps maybe a post-surgical leak, actually, I have had a couple of cases where patients who had, the two cases were actually people who had groin surgery, and they had, and looks like the lymphatics of the groin were actually disrupted, and they had chronic weeping lymphoria. One of them actually had both lymphoria and a chylous effusion from his right groin and scrotal area. And actually, we treated him with a Lymphopress pump, and we were able to resolve that treatment. And I think the reason why the drainage actually ceased and resolved was that we most likely were able to recruit additional lymphatics and actually get him drainage. So actually, that patient, if you are talking about somebody maybe with a very chronic draining lymphatic ulceration, he may actually be an excellent candidate to actually treat with a lymphedema pump, because you may actually get recruitment of new vessels and maybe resolution of that chronic draining area.
Excellent, thank you. There's another question here. It says, are there any precautions in reference to a pacemaker? And then she has comma ICD.
In terms of applying a device over the site of the pacemaker, I am not sure about that. Intuitively, I would say no, just because the pacemaker itself is protected when it is inserted into the chest cavity. So the pressure itself, I don't believe, will disrupt the mechanical workings of the pacemaker. Most of these pacemakers are designed to withstand up to 3 atmospheres of pressure. We put patients with pacemakers into the hyperbaric chamber, and that is pressurizing at 2.4 atmospheres, I mean, above atmospheric pressure. So I don't believe the pressure itself would be an issue. The Lymphopress device itself obviously does not provide any radio frequency signals that would interfere with the functioning of the pacemaker itself. So my answer would be, I don't believe so. I would have to look at it closely, but I don't believe I would be concerned about it.
And I will make a mention just from the manufacturing perspective that Lymphopress's advanced devices have the ability to turn specific chambers off. So, and we have this happen if a patient has a, maybe a port or, something where we need to turn pressure over a specific chamber, we're able to do that. So if for some reason that were a concern, or if this was an issue that we'd want to address, we can actually turn that pressure off and just skip over that area or lessen the pressure in that specific area if needed. Looks like there's one more question, and this seems to be more compression device related, so I'll address it. And then Dr. Anaeme, please, if you have any comments, please feel free to add to that. The question is, I have a patient with vascular disease who can barely tolerate 8 to 15 millimeters of compression. Can the pump be adjusted for these patients? So most of the devices, and our device specifically, can go down to just over 20 millimeters of mercury. So it's not going to go down as low as 8 to 15. But what we do find is that many patients can wear dynamic compression can tolerate at a much higher pressure than they can a static compression. So my suggestion would be to attempt using it with maybe even our peristaltic or our wave therapy. So if we have patients who have sensitive areas, what we typically recommend is that you would use the device in the peristaltic wave format so that it's only going to inflate 2 to 3 chambers at a time, and always allow the more distal chambers to stay deflated as it moves up the leg or the arm. So in a situation like that, my suggestion would be to attempt using the pneumatic compression and adjust some of not just the pressures, but also the therapy and cycle types to address that patient's need. We got a couple other questions that came in here. So are there still any concerns for pump and genital swelling? Years ago, it was stressed at high risk with high pressure. Is this still a consideration?
Not that I would be aware of, no.
No, I would actually mention, this comes from Kelly, the Lymphopress pants garment actually has a specific indication for genital edema. It has specific chambers that are designed to help reduce edema in that area. And there is a zipper if there's a catheter bag or for something that we need to address where we need to remove a port, like a port or something through that area. We can actually unzip through the crotch area and allow the catheter to be removed or taken out of the garment during compression. But that research, if we go back and look at where that came from, Kelly, that came from a very limited study with just a handful of patients. And over time, they really disproved that was the case. There certainly are times where patients may deal with genital edema. I think we've all been aware of that. But patients who have that predisposition, they're going to have that really regardless of what type of wrap or garment that they're wearing. So our device is actually meant to help with that type of treatment. So Dr. Anaeme, I don't know if I addressed that properly, but if you had any comments there.
Actually, but interestingly, Eric, I have actually had 3 patients in my practice in the last year who actually had this specific issue of genital edema. These were 3 women, young women. What happened? Well, I practice in Arizona, so they went over to Mexico and had cosmetic procedures and ended up with very large genital labial edema that as a complication of a botched medical procedure. And we fitted them with Lymphopress pumps as part of the treatment, and they actually did heal very well. They had dehisced wounds which healed up and the genital edema disappeared because they actually did have lymphedema, which I believe was post-surgically created. So this actually was a very successful treatment. And we've interestingly have had 3 patients in the last year who had this issue. And so I think actually the lymphedema pump would be a very effective treatment if you actually did have someone with genital edema for whatever secondary cause that they had.
Excellent. So there's one other question that's diagnosis related, and I'll try to address this. The question is regarding lipedema and pump usage. It says, lipedema and a pump is a great modality for a home program, but it needs a diagnosis code of I-89 for Medicare. Any hopes for coverage? So Kelly, I'll just address a couple things from a manufacturer's perspective, and then Dr. Anaeme may be able to speak to the medical portion of this. But you're right. There's a lot of proof of efficacy for the use of Lymphopress with patients to treat lipedema. We've seen this quite a bit. I would actually refer you to Dr. Karen Herbst has done a number of webinars with us. And if you go to our YouTube channel, just go to YouTube and type in Lymphopress. You can listen to Dr. Herbst's presentation on it. And her suggestion is that when you have even early stage lipedema, there is a lymphatic component. So lipedema patients typically have some lymphedema. So it would be a lipedema primary diagnosis with a secondary lymphedema diagnosis. And in that situation, you'd actually qualify for coverage as long as you've met the necessary criteria as far as compression and therapy and things like that as well. But Dr. Anaeme, do you have any experience with lipedema and pump usage or comments to that?
Not a whole lot, but I have had a few patients who have had primary lymphedema. I have several patients I've treated in my clinic, and I believe the diagnosis would be the same. I have never had to put a diagnosis of lipedema when asking for a Lymphopress pump, but I have had several diagnoses of primary lymphedema in young males and females. And I did get coverage. I mean, we were not denied coverage, so that's
great. And many times this is, the coverage conversation is almost a conversation in itself, because Medicare and most private insurances can vary can vary greatly. So sometimes it depends on what your insurance coverage is and what you're trying to get. But in the situation of Medicare, Kelly, my suggestion would be to look for that secondary lymphedema diagnosis to primary lipedema, and coverage should be granted. With that, we're just a couple minutes before the end. Dr. Anaeme, I want to thank you so much for your time today, your expertise on the subject of treating secondary lymphedema in a wound care setting, and for your excellent treatment of the patients that you treat in wound care and in the home health setting. Thank you very much for your time this evening.
Thank you. Thank you.
Thank you all. Thank you. Have a nice evening.